Hello, I'm Roger Gregory. It has been my pleasure over the past few years to host a series of medical interviews highlighting pioneers in vascular surgery. The first interview featured the legendary Michael DeBakey, who discussed Rudolph Mattis. In the second interview, John Oxner, son of the founder of the famous Oxner Clinic, discussed his childhood memories of giants in vascular surgery, including Mattis, DeBakey, de Tackets, and his father, Alton Oxner. Today's interview features another famous vascular surgeon, Dr. Frank Veith. Dr. Veith's titles, honors, and accomplishments would consume the entire time allotted for this interview were I to list them all. Suffice it to say, he has been president of every important vascular surgery society in the United States and is currently the professor of surgery at Montefiore Hospital in New York and Albert Einstein College of Medicine. Dr. Veith has over 600 publications as well as 290 book and book chapters. His most significant contribution, however, may be in the area of education. His annual symposium is attended by thousands of vascular surgeons from all over the world, eager to learn about the latest developments in vascular surgery. Further, Dr. Veith has not shied away from tough political issues and has been a strong advocate for the formation of an independent board in order to recognize that vascular surgery is a defined surgical specialty, just as neurosurgery, orthopedic surgery, cardiovascular surgery, and any and all of the other recognized subspecialties. Thus, Dr. Veith is ideal to discuss the evolution of vascular surgery as well as giving insight and perspective into what the future might hold for all of us. Before beginning the formal interview with Dr. Veith, it would be helpful reference to briefly review the highlights of the evolution of vascular surgery over the past century. Prior to 1900, vascular surgery was comprised primarily of wartime injuries treated by ligation. Reconstruction or restoration of the circulation was not truly a consideration. In the late 1800s, the great Rudolph Mattis developed endoaneurysmography, a technique for the treatment of aneurysms without graft placement. In 1906, Alexis Carrel, visionary surgeon, shown here on the right beside his engineer Charles Lindbergh, refined vascular anastomosis and transplantation among multiple other major accomplishments. In 1916, McLean discovered heparin, allowing vascular occlusion without distal thrombosis. In 1920, angiography was developed by Dos Santos, providing the first diagnostic roadmap for vascular surgeons. World War I and II brought advances in anesthesia as well as transfusion for the treatment of shock. In 1947, aortoiliac thromboendarterectomy was pioneered by Dos Santos, René Lariche, and Jack Wiley. This technique provided an effective method to treat aortoiliac occlusive disease without the requirement for a graft. In 1949, Kuhnlein introduced the concept of saphenous vein graft bypass for femoral popliteal occlusive disease. In 1950 through 1953, during the Korean War, vascular repair succeeded ligation, resulting in limb salvage rather than amputation for vascular trauma. This was a concept championed by Dr. Michael DeBakey. In 1950, carotid endarterectomy was introduced, pioneered by Mr. Felix E. Scott shown in this photograph on the left with Dr. David Hume. This was also pioneered by Michael DeBakey. Countless strokes were averted by this operation. In 1951, DuBose performed the first direct aneurysm repair using homograft. In the 1950s, arteriosclerosis was recognized as the primary process responsible for arterial occlusive disease. This was a giant step forward. In 1952, Voorhees developed the first prosthetic graft. This was a staggering development. In 1953, the first true fork in the road of evolution occurred. Gibbon developed the heart-lung machine, which was responsible for the subsequent development of cardiothoracic surgery. This is where vascular surgery as a species first stood erect. In 1970, cardiothoracic surgery was recognized as a specialty. In the 60s and 70s, Dr. Stanley Crawford devised a practical surgical approach to repair thoracoabdominal aneurysms. In 1974, Gene Stranis developed the duplex ultrasound machine and pioneered non-invasive vascular testing to complement angiography. This was a major contribution. In the 70s and 80s, distal bypass for limb salvage was pioneered and refined by several surgeons. John Manick in Boston, Frank Veith in New York City, Robert Leather in Albany, New York, and Herb Dardick in New Jersey, to name a few. The endovascular explosion represents the second fork in the evolutionary road of vascular surgery. Actually, it is a dual-lane highway rather than a divergent fork. This new pathway heralds back to the angiogram devised by Dos Santos in 1920, as well as the Sellinger technique for vessel access devised in 1953 as a foundation. The Fogarty balloon embolectomy catheter from 1968 led the way to all subsequent endovascular maneuvers. Dotter, pictured here on the right, suggested coaxial dilatation in 1969 to treat arterial stenosis. This was succeeded in 1974 by Grunzig, shown here on the left, who suggested dilatation of arterial stenosis using percutaneous transluminal balloon angioplasty, referred to as PTA. PTA was enhanced by stenting, a concept advanced by Paul Maas in 1990. Finally, in 1991, the genius of Juan Perotti led to the development of the endograft for abdominal aortic aneurysm therapy. In 2003, Veith, Dietrich, Moore, Hodgson, and many others have moved rapidly into the practical application of these techniques. In the 2000s, the future seems to hold no barriers for continued improvement in the management of vascular disease using both lanes of the dual highway, endovascular and open techniques. Dr. Veith, thank you for making time to discuss these important items today. And basically, I'd like to start off by asking some specific questions, which may, of course, lead to other things. The first question is, in your mind, how and why did vascular surgery evolve? How did this happen?
Well, it's a long history, Roger. The surgery of blood vessels has always been part of surgery, going back to the early days of the surgery of the war wounded and so forth. Vascular surgery as a defined specialty in my mind, and in the mind of many others, has now come to be the specialty that deals with all forms of non-cardiac vascular disease. And how we got from that early day of just treating war wounds of blood vessels to where we are now is a fairly long story. Basically, vascular surgery started to evolve in the 50s and 60s, along with the surgery of the heart, so-called cardiovascular surgery, as we developed techniques to do heart-lung bypass, and as we developed techniques to operate on lesions of arteries. And there was a rapid growth of interest in what was then vascular surgery, and it grew as part of cardiac surgery and general surgery as an outgrowth of it. Many individuals did vascular surgery operations as part of these other two specialties, and things went along pretty well. And then as the techniques became a little more specialized and a little more complicated in the late 60s and 70s, it was realized by some of our founding fathers, notably Jack Wiley, that the results of vascular surgery, that is operating on blood vessels, was better if somebody confined their entire practice or most of their practice to the treatment of vascular diseases and operations on blood vessels, particularly arteries. And there was a impetus at that time to form vascular surgery into a specialty, or at the very least a subspecialty. And indeed, there was a movement to that end in the early 1970s. Unfortunately, that movement was opposed largely by other specialties, notably general surgery and some of the other specialties which also did some operations, very few, but some operations on blood vessels as well. And at that time, there was a lot of conflict and hostility, and we ultimately got a certificate of subspecialty specialization in vascular surgery around the early 1980s. That was sort of given to us as a bit of a sop to blunt the effort to have an independent specialty with its own board and RRC and so forth. And that continued on through the 80s in a fairly satisfactory way, but it became obvious that vascular surgery was encompassing more than just operating on blood vessels. Vascular surgeons became the specialty that deals with the natural history of vascular disease, the conservative management of vascular disease, the medical treatment of vascular disease. There is no other specialty that really does that. And when I say vascular disease, I mean non-cardiac vascular disease. We also became experts and developed techniques for non-invasive diagnosis, both in the vascular laboratory and in the angio suite and other techniques of that sort. And we refined and developed and evolved our operations, our open operations on blood vessels to the point where they became far more complex and detailed and demanded greater skill and training. And then in the late 1980s, the endovascular revolution was thrust upon us, and it was developed both by vascular surgeons, the early developments by radiologists, interventional radiologists, and even some others. And this started out in a very sort of subtle way as supplementary techniques to what we were doing with open vascular surgery and other treatments. And then as time went on and we got into the 90s, in addition to catheter-directed thrombolysis and perhaps balloon angioplasty, so-called plain old balloon angioplasty, we had the introduction of stents and stented grafts. And that really was the cataclysmic part of the endovascular revolution. That was the major explosion because it basically facilitated the treatment of many, many vascular lesions which heretofore had to be treated by open surgical techniques or not treated at all. Now, as this was happening, there was also evolution and development in the knowledge base in vascular disease, the natural history of vascular disease, the medical treatments of vascular disease, and so forth. And all these advances basically came to a point where anybody that wanted to master these techniques would require more training, special experience than would be possible in a year or two of residency, which was tacked on to some other form of residency.
When you say that vascular surgery had evolved into that position, exactly what do you see as the pillars of vascular surgery?
Well, as I've sort of implied, vascular surgery constitutes the specialty that deals with non-cardiac vascular disease. And if one is going to deal with that, one has to master what we call the 5 pillars of vascular surgery, which are understanding and knowing the natural history, so you know that the treatment is going to be better than the natural history, or worse, and can therefore apply it appropriately. One has to master the non-interventional treatment, that is the medical treatment or conservative treatment of vascular disease. One has to know and understand and be able to apply all forms of invasive and non-invasive diagnostic techniques as they apply to these vascular disease, so you can define the pathology. One has to know all forms of open operative treatment on blood vessels. And one has to master the endovascular techniques, right, which also can be used to treat these lesions either with or without a component of open surgery. So those are the 5 pillars, as we see, of vascular surgery. And obviously, in the 1950s and 60s, someone who was doing vascular surgery had to master maybe 2 or 3 or 4
right,
operations, usually on fairly easy or standard cases. As time has gone by, we've had to master many varieties of those basic operations, usually in circumstances which are really quite difficult because of the nature and extent of the disease. So in the late 1990s, it became obvious to many of us, and since I was an early advocate of endovascular techniques going back to the early 90s, I saw early on that vascular surgery no longer could be restricted to a few operations done as a sideline of either cardiac surgery or general surgery. And I and some other people felt that at that point we had to modify our training paradigms, right, so that a vascular surgeon could devote the bulk of his postgraduate training to the specialty in which he was going to have to be expert in all these 5 pillars.
Vascular surgery as a distinct specialty with an independent board. Do you really believe that this will happen soon?
That's a very good 2-part question, Roger. Vascular surgery, in my opinion, is already a defined specialty. I don't do general surgery operations. Many of my colleagues don't do general surgery operations or cardiac operations. We just take care of patients with non-cardiac vascular disease, and we do vascular operations, endovascular interventions, medical treatment, the whole gamut. So clearly vascular surgery is already a defined specialty. The second part of your question, having to do with whether we should have, as recognition of that definition, an independent board of surgery, it's a no-brainer as far as the answer is concerned, the answer being yes. The difficult part of that question is, how do we get there? Because at the present time, there is very strong opposition to the evolution of independent board status of our specialty. And there has been this going back to 1970.
Now, Frank, why has vascular surgery been different in their relationship specifically to the American Board of Surgery? Was this the case with vascular surgery? I mean, with thoracic surgery, cardiac, neurosurgery, urology, orthopedics? Why is vascular different?
Well, some of the independent surgical specialties, like orthopedics, ENT, ophthalmology perhaps, neurosurgery, evolved earlier on. Some of them actually formed before, had independent board status before the American Board of Surgery was formed in 1937 to represent general surgery or all of surgery. So some of those early boards didn't have the opposition that we're encountering, but cardiothoracic, which became an independent board, I think in 1970, they had intense opposition from the American Board of Surgery.
Interesting.
And in many ways, the history of that evolution of cardiothoracic surgery parallels the history, their difficulties parallel the difficulties that we're going through right now. So, yes, some of the other boards have had that difficulty, particularly in recent years. And the sort of follow-up aspect of the answer to your question is, why would an American Board of Surgery, why would we have all this opposition? Quite honestly, I don't know as I can answer that because I don't see inside their minds, but it's been clear to me that there are a variety of vested interests, that there's a tendency of the older guard who people the American Board of Surgery and who represent large general surgery departments to maintain the status quo because they maintain their power, their economic advantages to them, control advantages, all the things that go along with maintaining an empire, which has been responsible for vascular surgery being kept in a subordinate status, a colony of the empire, as you will. And there's no question that the excuse that the American Board of Surgery has given is they don't want to, quote, further fragment surgery. Now, what's meant by that, that's a buzzword or a code for maintaining the status quo.
Frank, what can the everyday vascular surgeon do to promote the reality of an American Board of Vascular Surgery?
There's a great deal that they can do. At this point in time, more than anything else, we need the intense and committed support of every vascular surgeon, or at least as many of them as we can possibly get. Getting that support will help to demonstrate the unanimity within our specialty that we're unified in this quest. And the way the vascular surgeons can do that is by speaking out in favor of this at meetings and in their own interactions, how important it is to them to have a defined specialty, to their reimbursement, to their training issues, to getting a young, well-trained endovascular trained guy to join them in their practices if they're senior, so that they can be trained without leaving their practice. And specifically what they can do is they can make a donation to the American Board of Vascular Surgery. Now, we've asked for substantial amounts from people, but even a small amount from every vascular surgeon will not only help us financially to educate the public and the profession about this issue, about the rectitude of it, but will also demonstrate that there's unanimity in the specialty. So we really need every vascular surgeon to make at least a small donation to the American Board of Vascular Surgery in the near future so that we can express the unanimity within our specialty.
We have discussed some of the early pioneers in vascular surgery, but specifically, who influenced you?
Well, the people that influenced me and that I admired most greatly, I've thought a little bit about this. Stan Crawford, to me, was an absolute giant because he solved difficult problems in a particularly unique and effective way. Julio Palmez, the innovator of the stent, had a major impact on my thinking and career and really got me thinking about endovascular procedures. Barry Katzen, at whose meeting I met and learned about Julio Palmas before any other vascular surgeon even knew he existed. And Barry is also an innovator and a promoter in the good sense of simplified, less invasive treatment of lesions. There are many, many others that along the way. Of course, Juan Perotti was a major influence on our career because he got us started with the endovascular grafting at a very early stage.
Needless to say, there are multiple overlap issues regarding other specialties and even involving certification. Do you think these are resolvable issues? How should they be addressed?
First, we have to consider that the basis of all, or the reason, the goal of all specialty boards and specialization is to permit better care of patients through specialization.
Absolutely.
And indeed, in vascular surgery, the purpose of having an independent board is so that we can better train our trainees, our young vascular surgeons, so they can be competent in all aspects of vascular disease management, and so they can provide better care to patients.
Frank, do you think the training programs and paradigms that we have now for training vascular surgeons are okay or satisfactory, or do you think they need refining in a modern era?
They clearly need refinement. And one of the thrusts, and most of us who've been active in this quest for independence and improved training, and they go together, most of us have tried to compromise with the American Board of Surgery to modify our training paradigms while we could still stay within the fold of surgery, as it were. That's not been possible. The idea of spending 5 or even 4 years, which is a proposed modification, in general surgery training, and then having 2 years or a year of vascular training tacked on the end, that just doesn't make sense.
It's not enough.
It's not enough. Plus, the sop which we've been thrown, the bone which we've been thrown, of having a 4 and 2 program has been so compromised and is so complex and so delayed that it's never going to happen. So we're really faced with the dilemma of maintaining a status quo which is totally inadequate and which will fundamentally destroy vascular surgery and prevent us from providing optimal care to patients, or having an independent board which will allow us to go with other paradigms where we have 2 or 3 years of general surgery and then spend the rest of the time, 3 or 4 years, devoted to the specialty which is going to consume the rest of our professional careers. One other point, there is no reason that a vascular surgeon has to know how to take care of breast disease, thyroid cancer, malignant melanoma when he's never going to do that.
Right.
And we think that time is much better spent learning the imaging, the non-invasive diagnosis, the endo procedures, and the natural history of vascular disease.
Another aspect of overlap issues with cardiology and radiology specifically, they have such an strong institutional support and resources. How can vascular surgery compete with this?
That's a great question, Roger. The only way we can compete, because as you mentioned, some of these other specialties, notably cardiology, is extremely powerful within institutions. They have large numbers, they're well financed, they have political clout and so forth. The only way we can compete with these individuals, if all of them want to take over our area of interest, is to do it better than they can. And the only way we can do everything better than they can is to have adequate training in the 5 pillars that we mentioned, which allows us not only to do all the manipulations, interventions, and operations better, but allow us to provide better care of patients because we know when not to do procedures. And that's probably as important as anything else. If we can master these 5 pillars and then make the public aware that we've mastered these 5 pillars, they'd have to be crazy to go to a less well qualified and trained individual.
Very persuasive. You've touched on the goals and objectives of the American Board of Vascular Surgery, specifically as relates to education, better training, better patient care. What about, and I hesitate to even mention this, but I think in today's backdrop, this is a very important area, and that is the area of politics. Where does vascular surgery and what does the American Board of Surgery want to do relative to public education, a seat at the table to negotiate reimbursement schedules, perhaps a national registry? Where do you see the American Board there?
The American Board is really, I don't think, interested, nor do they have the responsibility for doing all those things. I think even an American Board of Vascular Surgery wouldn't necessarily by itself do all of those things. Some of those are the responsibility of the professional vascular societies and so forth. Vascular surgery has been ill-served in the past by being represented in reimbursement negotiations with the government by general surgery,
right,
who felt that the vascular operations were trivial. A fem-pop bypass is maybe, in their mind, the equivalent of a hernia operation, because they really don't do that. Vascular surgery has also been ill-served when they've been represented by cardiothoracic surgery. So that we clearly have to differentiate ourselves and define ourselves as being different from cardiac surgery, which we clearly are. They do largely pump oxygenator procedures. We operate on blood vessels that are unassociated with the heart. And that's been true, that differentiation has been occurring since the early 1970s. We clearly have to differentiate ourselves from general surgery. We're not the same specialty anymore. There may be individuals who want to do general surgery and vascular surgery, and if they wish to take the appropriate training to do both, that's part of our American Board of Vascular Surgery application. There should be tracts which allow people to do both general and vascular.
Let me ask about another possible threat that may be seen as far as the activities of moving towards having a separate, distinct specialty board of vascular surgery. Dr. Stanley has brought out in his surveys the fact that a large percentage of vascular procedures done in the country are actually done by non-vascular surgeons. Do you think the threat that they would be unable to do these operations plays any role in?
No, again, it's a complicated question, and the answer is a little bit complicated. There are individuals, general surgeons, doing vascular surgery that fall in many categories. Some of them dabble in vascular surgery, which of course we think is a bad thing. They may do 1 or 2 vascular operations a month, and clearly will have less good results with those operations. There may be other general surgeons who do not possess a certificate of special qualifications or added qualifications in vascular surgery who do a lot of vascular surgery, right, and are really de facto vascular surgeons. It would be our hope that those individuals would be able to qualify and take the exam, right, as a vascular surgeon, and if they pass it,
become legitimized.
Become legitimized. There's a so-called disenfranchised group that have been well-trained, do a lot of vascular surgery, but are not allowed to sit for the examination. We think that's a bad thing. And then there are a lot of shades of gray in between. The older general surgeon may do some simple vascular operations, may do dialysis access. Right. The older general surgeon, I hope I didn't misspeak and say vascular surgeon. The older general surgeon,
that's us, Frank,
may do some simple vascular procedures, but I think that probably, because of malpractice issues and other concerns, liability concerns, I think that's becoming less and less. So clearly, we are going to need more vascular surgeons, right, as the number of elderly increase and the baby boomers hit the elderly over 65 status, we're going to need to train more vascular surgeons. With the present arrangement, where we're obligated as a vascular program director to give a large number of vascular major arterial procedures to our general surgery residents who are never going to do them, we won't have enough case material to train an adequate number of vascular surgeons, and the public again will be ill-served by the present system.
Frank, you've spoken very eloquently about the history and evolution and development of vascular surgery. I'd like to move now a little more towards the present and perhaps the future. The first thing that I'd like to ask about are overlap issues that you've already touched on somewhat, and certification. And if you feel that these are resolvable issues, specifically invasive cardiology and radiology, these are important everyday issues for the practicing vascular surgeon. Many of these individuals find it difficult for political and local reasons to gain access to an adequate angiogram suite. Do you think that vascular surgery should certify all interventionalists, or should each take a separate board, or, if a separate board, a common and national registry developed that would level the playing field, perhaps?
Okay, that's again a very good question. My thinking may not represent that of many of my colleagues who share my enthusiasm for an independent board of vascular surgery, but I believe that interventional radiologists and interventional cardiologists who have a commitment to and are well trained in all aspects of non-cardiac vascular disease should be able to do it. What we object to, or what I personally object to, is the interventional cardiologist who knows nothing about the natural history of vascular disease, who, because he can place a balloon and a catheter and a guide wire and has his own angiography suite, feels that he's capable of treating non-cardiac vascular disease. I think that's bad. If an interventional cardiologist wishes to devote the majority of his practice to non-cardiac vascular disease, if he's good at it, and if he has the education and training in all parts of the disease and all aspects of its management, then I think he should be credentialed and empowered to do so. I think just because he can do cardiac caths doesn't mean he can do renal and carotid interventions. And I've seen at meetings over and over again where an interventional cardiologist will treat an asymptomatic patient with a 30% stenosis with a stent. Doesn't know that such a patient is better served by not being treated at all. And similarly with renal angioplasties, we've seen the same thing. So my concept about this is, I think if we get an American Board of Vascular Surgery, we probably should move in the direction of having an outgrowth of that board or supporting another board, preferably an outgrowth of our board, where somebody that meets the requirements of committing their practice to non-cardiac vascular disease and having adequate training in that area of interest should be able to sit for our board or a related board or a component of our board. Perhaps there should be multiple pathways and multiple exams that are given to such individuals so that the necessary number of physicians can be created who will treat the disease competently when indicated and well.
Frank, I have to bring this up. You've been labeled as an isolationist because of all your activities about trying to develop a separate board. You want to take vascular surgery away from everyone else, from the mother board of general surgery, and yet I find it interesting that you're talking about being inclusive. How can this be?
Well, I've been labeled lots of things.
Well, what is your position?
My position is that those who are competently trained and who largely specialized in the area of the disease that we're talking about, and assuming that they have access to the various pillars that we're talking about, which enable them to provide optimal care for the right patient, I think all those individuals should be eligible to take an appropriate qualifying and certifying exam, and if they pass it, they should be considered eligible to practice that specialty. That includes some general surgeons who are now not boarded or have no specialty certificate. It certainly includes some interventional radiologists who are very competent in this area and have indeed pushed the envelope forward, and it includes interventional cardiologists who've done the same thing and who are committed largely to this area rather than cardiology. They're not really interventional cardiologists, they're really interventional angiologists. But the word cardiology connotes heart, and that's a separate specialty, no more than we should be doing coronary stenting, which is apparently pretty easy to do. But I don't think we should do it because we don't know how to take care of the heart to the same extent that the interventional cardiologists do.
Just so we don't reinvent the wheel, how did these other specialties that separated from the American Board of Surgery deal with these overlap issues? What did orthopedics do? Neurosurgery, urology, some of these other specialties that had overlap.
There always is going to be overlap, and we'll never have a perfect world. But again, I think what we want to come out with is a world that is largely right. And we think that having an American Board of Vascular Surgery at this point in time, with the evolutions of all the techniques and the new knowledge and the new methods of doing it, we think that the time is right to have a specialty board and to not obligate us to train as general surgeons, which is not what we are, in order to hold this holy grail of a subspecialty certificate tacked on to 5 years or 4 years of unnecessary training.
The way you present things, Frank, it sounds so reasonable. Who is really opposing this separate American Board of Vascular Surgery? What's going on here?
There's no question, if you discuss these issues with a layperson, a judge, a lawyer, anybody, it's a no-brainer. What we've said is a compelling argument to have an American Board of Vascular Surgery. However, life is really a political experience, and there are those whose interests may be poorly served by this evolutionary development. The American Board of Surgery opposes us both vigorously, strongly, and to some extent dishonestly. They have circulated far and wide letters, statements, much of which is untrue, or part of which is untrue, as to reasons why the system, the whole system, will come apart if the American Board of Vascular Surgery comes into being as an approved American Board of Medical Specialties specialty. The same thing was said about cardiothoracic surgery when it came into being, and interestingly enough, the world didn't come to an end. Some of the statements which we've read, I call the sky is falling statements, that the American Board of Medical Specialties will come apart at the seams if vascular surgery becomes an independent board. Unfortunately, the American Board of Surgery is very powerful. They've done a lot of good deeds for other boards, and they're now calling in their favors to block us. And I think they were pretty effective in that effort. Moreover, they've managed to co-opt a number of elderly vascular surgeons, some of whom are prestigious names and leaders in our specialty, and presumably they've managed to motivate them to turn on their specialty and support this sort of archaic and ineffective status quo. And these leaders, these elderly leaders who've been co-opted, whether it's either by their philosophy, the fact that they're living in the past, or whether they've been given rewards within the general surgery system, I really don't know. But something has happened that some of these vascular surgeons have been very effective in turning aside our effort and making it appear that this is not a unified goal within the specialty of vascular surgery, when in fact it is.
Yet, multiple questionnaires and polls have been taken of the vascular surgery community. All of these, it's more or less like the election in Florida for President Bush. No matter what the count was.
There's some of that. There's no question that older vascular surgeons, particularly those who are retired or are well connected to general surgery departments or groups, oppose this. They've been asked to oppose it, and they've gone along with the party line. Young vascular surgeons, those in practice 10 years or less, it's 80% support this, and probably now, that was an old poll when those figures were determined, I'd say 90% of graduating fellows and others who are into the modern era say, what's the question? Why don't we have a board? Right. The other problem that we face is that the American Board of Medical Specialties is somewhat unwieldy organization. It's peopled largely by individuals who are elderly, that are part of the establishment, that aren't willing to see the need for change, and really the ABMS system doesn't have a mechanism whereby this is easily accomplished. It's an enormous battle.
Clarify for us exactly what this group does and what the position they hold and why they're so powerful in this
The
struggle.
American Board of Medical Specialties is an organization whose purpose is to improve care by specialization. So we fulfill their mission perfectly. And we also fulfill all the other requirements to be an approved board of the American Board of Medical Specialties. And our application amply demonstrated that. The problem is that the American Board of Medical Specialties is made up of representatives of other established boards. And there's sort of an old boys club, we think, within that organization, which has an interest in maintaining the status quo. One vested interest supports another vested interest, and that's okay to a point. But we think that point has been passed, and the time has come that this should happen. This is a quest which has been going on since 1970. And we've been shunted aside by small, insignificant gifts, as it were, thrown a bone here and there, but the substantive issue hasn't changed. And the requirement to train every general surgeon to be a vascular surgeon persists. And that is a problem, plus the problem in recruiting trainees into vascular training programs is an enormous problem because of the length of the training, because of the fact that it's not a simple, that the whole field of medicine is complex, reimbursement is less, and so forth. Add all these things together, and we really need to have an efficient system where a vascular surgeon can train in a reasonable amount of time and be rendered super competent to take care of patients with non-cardiac vascular disease.
Frank, you seem to underline the fact that the future is now. We've gone from the propeller age to the jet age. The future hinges on what happens over the next 2 to 3 years, according to Frank Veith. Why is that true?
Well, I think what I said earlier about not getting an adequate number of high-quality applicants for our training programs is real. Many programs didn't match this year, many vascular training programs.
Wow, I didn't know that.
And those that did match didn't always match with very high caliber individuals by whatever criteria you want to look at. This is a complex problem. It's related to an unattractiveness in general for surgical specialties as opposed to other medical specialties. But I think it's probably is worse or as bad in vascular surgery as in other specialties. And we think that can be altered. The surgical specialties with shorter training programs where the specialization is more intense earlier are very sought after and are not having trouble matching. vascular surgery is a very exciting field. There's a lot of good stuff going on, and a lot of good research to be done, clinical and basic. And we should be picking off very top candidates, and many of us think that we would if we had a 3 or 4 year vascular training program superimposed on a shorter period of general surgery.
More comprehensive vascular.
Right.
Touching on politics again, do you think personal politics will hamper the development of new leadership dedicated to vascular surgery rather than the old American Board of Surgery?
I've always felt that once we start to really move forward with a separate board and high definition of our specialty, that the dominoes would begin to fall. Unfortunately, the strategy of our opposition has been to pick off the domino leaders and in some way co-opt them, as I've mentioned, into the camp of maintaining the status quo. That's a problem. I think if the control of all our societies rests in the hands of the very small minority of such leaders, I think our specialty is in trouble. The societies have to be somewhat, it was very militantly in support of this when I was president and in my immediate past presidency year. Since then, the support at the top echelon of leadership has been a little bit inconsistent, and that's hurt us a lot also.
Do you think that the so-called American Board of Surgery loyalists in vascular surgery can be brought on board smoothly?
I really don't know. It depends how intensely they've been motivated to oppose us and what their perception of their gain, their personal gain for opposing this initiative is. And I really can't read that. I mean, we've had discussions, very collegial discussions with many of these leaders, as we've had very collegial discussions with the American Board of Surgery. We tried to strike a compromise during Ramon Berger and Bob Hobson's year as president. They spent the better part of a year trying to get agreement on having a vascular board down the corridor from the ABS, which was a very reasonable thing to do.
Yes.
We would have given a lot of leadership board director appointments to the American Board of Surgery and compromised, but they rejected us out of hand and in a very supercilious way.
I know this has been a disappointment to you, Frank, personally, but we all hope that your efforts will continue. I have one last question that may be somewhat explosive, but do you think that new giants in vascular surgery to replace Veith, Jim Stanley, Ernst, Fogarty, Ted Dietrich, do you think these individuals are growing in the wings?
Oh, sure. A lot by leaps and bounds. I mean, there are very many, I mean, Jim Stanley and I and the others you mentioned are at the mid portion of our career, but there are many other individuals who are younger in their careers who are probably far better than we are. They're more articulate. They're just as intense about these issues. And I think our specialty is very healthy in having such leaders by the score who can rise up and deal with this. And fortunately, many of those are very firmly in the camp of independence. But good things don't come easily. And some of us who've been at this a long time would like to see it happen within our lifetime, and hopefully it will.
Clearly, the future is a real challenge for everyone who is dedicated and interested in vascular surgery. Frank, you have shed light on both the evolution of vascular surgery and the fact that defining our specialty is clearly our challenge, both now and in the immediate future for all of us. Thank you for your insightful discussion.